Hi everyone, this is Melissa Fleetwood and I am guest lecturing for your nutrition pathophysiology class. We are talking about HIV and AIDS. So I am really excited. For those of you who don't know me, I've been working with HIV, or I should say I've been working with patients who have HIV and AIDS since 2016. I took nutrition pathophysiology in 2015. And even in those last 5 years, there have been so many changes for the better. We've got better medications and just overall better treatment and great life expectancy and outcomes have improved. So much has changed for the better, and I'm really excited to be talking with you today about that. I did my best to stay as close as I could to the textbook as far as or in terms of how the information is presented. I tried to follow the same order that's in your textbook. Forgive me, I may have moved some things around. But I also incorporated new statistics. I incorporated new medications, the latest that are on the market. And if there's anything I didn't get to in this presentation, please feel free to email me. You have that now, melissa.fleetwood@unlv.edu. I'm more than happy to answer any questions that you might have had in this lecture, any knowledge gaps, any areas where you would have liked more information. So I did my best to not go overboard because HIV and AIDS is my jam and I could talk to you for hours about it, but we are saving that and we are I tried my best to stay within our hour time frame. We might get at 45 minutes, we might get at 50 minutes. I did my best to account for if we were to have an in-person lecture, some time for Q&A. So I'm excited. Grab your liquids, grab your snacks, because we're going to get started. And this is pre-recorded, so if you want to take breaks, you totally can. I'll be providing the slides so that way you can print them out and follow along if you prefer that method. I know that's my preferred. So yeah, I'm excited to be here, excited to talk to you about it. HIV stands for Human Immunodeficiency Virus. This virus targets host immune cells and turns them into viral factories for HIV reproduction. We talk about the pathophys a little bit later, but it's just a note on this. I have seen lab values with patients that are newly diagnosed and their viral load is in the millions, so that is very true. It's really interesting how resilient the body is and just how tough and strong the body is. I'm not a doctor, but the doctors I've worked with could, or if you guys ever wanted to shadow someone who is an infectious disease doctor and works with HIV patients, I mean, they can tell you how long potentially this patient has had HIV. Just super fascinating. Just how strong they are. I'm just imagining feeling really fatigued and run down for months or some cases years and just never coming to the doctor to get a checkup. It's really interesting. It'd be really great if you ever had the chance to do a rotation. If you were to go through the dietetic internship, it would be really great for you to be able to do a rotation in HIV/AIDS care. Just really, really interesting stuff. And then AIDS stands for Acquired Immunodeficiency Syndrome. This is a symptomatic condition making the individual vulnerable to opportunistic infections that can cause disability or death. Later on in the presentation, we go over how one acquires an AIDS diagnosis. And HIV is transmitted via blood. It can be transmitted through fluids like seminal fluid or vaginal fluid, but the highest concentration of viruses are found in the blood. And then the transmission is through sexual contact, a blood transfusion, which now we screen blood. So there's part of the form. That one fills out, from what I'm told, when they want to donate blood, asks if you have an HIV diagnosis. But even after that, they screen all of your blood, and even sometimes that's the reason why people will come in for a confirmatory test if they donated blood and the blood is tested and it's found that there's HIV virus in the blood. Since they're not doctors, those who work at the blood donation banks, they cannot diagnose, so they contact the patient and recommend them that the patient go to a medical professional, doctor, to be given an HIV confirmatory test. So that typically is done at the Southern Nevada Health District. But it can be done in other places too. But typically, everything goes through the Southern Nevada Health District. It's much easier because they have to, or I shouldn't say easy. It is easier, but also it's recommended or preferred because SNHD sends all of their data to the CDC, so that it's best. I would hope that there's protocols in place for any infectious disease doctors that do confirmatory tests at their locations. I would hope that they're also reporting their numbers to CDC, but I'm not sure because I haven't worked there. But I have worked at the Southern Nevada Health District, so if anyone wants to pick my brain about what it was like working there, feel free. Okay. Blood that's also transmitted via IV needle sharing. This is less common, but it is still common. You'll see I have a figure in another slide. And then perinatally, yes. So if a mother has HIV, then it is recommended that she have a cesarean birth, a C-section, rather than a vaginal birth because there's less risk of transmission. Additionally, the mom will be placed on HIV medications specifically so that she will not transfer HIV to the fetus. Additionally, when mothers do give birth, those who are HIV positive, we do not recommend breastfeeding because HIV virus can be transmitted through breast milk as well. So there you go. All right, so there are approximately 37.9 million people worldwide living with HIV and AIDS. This is from a statistic from 2018 found at hiv.gov, and I include the website at the bottom if you want to check that out. A lot of people that I talk to I tell that I worked in HIV/AIDS sector, a lot of people don't believe that HIV diagnosis are still occurring or that it's a prevalent issue, but it certainly is. When I was working at SNHD, there were at least 2 new HIV diagnoses per day that I was there, and that's just here in the city of Las Vegas. Although we don't have the best track record, we are highest in the nation. We always go either first, second, or third in all of the STIs. Just statistically over the years, we're number 1, number 2, or number 3 for all the STIs: chlamydia, gonorrhea, syphilis, and HIV. I don't know the stats specifically for HIV in Nevada, but I would assume that they are high compared to the rest of the nation, given our high STI track record. And there are still AIDS-related deaths. They have gone down since 2004. However, in 2018, around 770,000 people died from AIDS-related illnesses worldwide. I can't speak for globally, but I can speak for in the U.S. This does occur particularly with people who do not know that they have HIV and just go on living without getting treated. The other thing is sometimes patients who have HIV choose not to take their medications. We do our best to counsel them and encourage them and, give them all the pros and the benefits to taking HIV medication, but some people really do fall out of care, and that's a reason for death. Another reason for death can be that if they're untreated if they're untreated or choose not to take their HIV medications, another thing can be other opportunistic infections or other diagnosis that they may acquire that's just too hard on the body. A lot of times it's pneumonia, but that's not all the time, but a lot of times it can be that. So it's unfortunate. So this is still HIV is still a very prevalent topic, and as we get to the stats and the next slide, you'll see that it's still relevant to talk about. It's still relevant to know how we reduce the risk of transmission. Around 1.1 million people living with HIV are here in the U.S. However, nearly 1 in 7 of these people are unaware they have HIV. So you would think, oh, but if you read the textbook, like, oh, typically they have flu-like symptoms. Well, sometimes they do, and sometimes those symptoms, depending on how strong a person's immune system is, they may not they may not experience those symptoms for months or years for some people. I met a guy who's newly diagnosed and who potentially had, this is according to what the doctor had told me, he had potentially had HIV for 10 years. And I don't know if during those 10 years he was diagnosed and in denial or what, but it's pretty fascinating. He hadn't been on any treatment and finally came in to start treatment, but I definitely wouldn't risk it. And once you start experiencing those symptoms, or not you, but our patients, whomever, they can be pretty intense. So, and there's great medication now. So, um, it's just, there's so many benefits now to how we're at medically and how we've progressed, that there's no reason for that. But everybody has a choice, and that's their personal choice to make. Okay, so of the 37,832 new HIV diagnosis in the United States in 2018, here's the breakdown. 69% identified as gay, bisexual, or other, men who have sex with men. 24% were heterosexual, and 7% were IV drug users. So I included this graph, or I should say, graph table, to just show you the breakdown, because it includes ethnicity and sexual orientation. So in case you were interested in the numbers, they're here. You can go to the CDC, HIV.gov. They have AIDS info. They all are great websites for getting the latest stats on HIV. So this slide is just a review. This is from chapter 9. So this is just a review so we can start thinking about pathophys and how wounds are treated in the body. Under normal circumstances, the body is able to, it has a plan how to eliminate an invasion, right? So this is an example of a break in the skin where bacteria is introduced and can reproduce at that wound site. And then this initiates a cascade of additional events, such as macrophages engulfing pathogens and secreting cytokines and chemotaxins, and then activating mast cells that release histamine. Histamine dilates the local blood vessels and widens the capillary pores. The cytokines cause neutrophils and monocytes to stick to the blood vessel wall. Then chemotaxins attract neutrophils and monocytes, which squeeze out between cells of the blood vessel wall, process called diapedesis, and migrate to the infection site. Lastly, monocytes enlarge into macrophages. Newly arriving macrophages and neutrophils engulf the pathogens and destroy them. So this is really important to review because there are issues that occur with HIV, this virus specifically, whereas macrophages and neutrophils are good at engulfing pathogens and destroying them. There are issues when it comes to the virus. The HIV virus is very tricky. So I really like this graph. I think it's great. I think that it's straight to the point and it gives us a clear picture of what's going on. Feel free to take a gander and to review even after this lecture, because it will take some time for things to seep in, I should say. So what we're looking at is the HIV virus and how it's entering the cells. It's very tricky. This virus identifies the target CD4 cell and fuses to the surface. So you're seeing this is what's happening in steps 1 and 2. HIV injects RNA, enzymes, and other substances that assist in viral integration and replication. So the HIV virus is utilizing the host cell's processes that already exist, and as it's infiltrating, these processes continue, not knowing that the HIV RNA and DNA is being introduced and replicated. Using its own kit of injected substances, HIV RNA is transcribed to DNA particles using reverse transcriptase enzymes. So you're seeing that in step 4. The DNA is carried to the nucleus and integrated into the host DNA using the HIV's integrase enzymes. You're seeing that in step 5. At this point, the integrated viral materials can remain dormant until they are activated, at which time they command the cell to become a viral factory that manufactures viral components. Protease enzymes cleave the viral proteins for assembly into viral cores. Once fully assembled, the virus is ready to bud out of the infected host cell. As the host CD4 cell manufactures, assembles, and releases viruses, it is incapacitated and destroyed. In addition, macrophages harboring HIV are rendered dysfunctional. And it's through this process that the immune system is compromised and the HIV disease progresses. So it's pretty intense, all these steps and just how HIV enters the cell. What's really great is the fact that we know this pathophys and we understand what's happening because this is how HIV medications were developed. They were developed to stop at different parts of this process. So we get into that a little bit later, but that's the breakdown. This next slide is a nice recap of what I just said. Another really great recap, if you have the textbook, is on page 712 under the Pathophysiology section. I would assume you're reading your textbook before and after lecture so everything sinks in. If not, this is a friendly reminder to do that. So I just in this slide, it's just a summary of what I just went over. If you have, like I said, if you have any questions for me or for Michelle, please ask. But the picture I find is the best at the summary and just following the steps. And then, like I said, it's going to come back into play later on when we talk about HIV medications. So, long story short, host CD4 cells manufactures and releases viruses and is destroyed. So not only are these CD4 cells being infiltrated and reproducing the virus, but they're also being destroyed in the process. So it's not in this slide, but it's in a later slide. Basically, the HIV viral load goes up and your CD4 count goes down. So that is not good. And this is how one becomes immunodeficient and or immunocompromised. I included recommended videos, so everything that we just went over, because we're sciencey nutrition people, that's a great breakdown pathophys. But if you are anyone like me who likes simple, like how do you say that without all the jargon and in layman's terms, if you check out on YouTube Help Stop the Virus, if you just type that into YouTube, you'll be brought to this YouTube channel, and there's a great video that's entitled, let me see what the title of it is. I believe it's called I wish I remember the exact title, but it's something like What's Going On in My Body. If you type that on and then if you type that in and then type HIV, it's part of this Help Stop the Virus channel. But it's a really great video and it goes through what I said, but in really simple terms. And I find starting there, listening to that summary and then coming back will be really helpful for you grasping the larger process. Okay, here it is. HIV, what's going on inside your body? Yep. Okay, so I was pretty close. Okay, so at the onset of the HIV infection, sometimes, like I said, it's accompanied by flu-like symptoms. A lot of times it's not. Or like I said, it takes months or years for that to start happening. One thing that I constantly recommend to not only my patients, but my students is that if you're sexually active, the current recommendation according to the CDC, I forgot to include that, my bad. I can grab that for you. But according to the CDC, if you're sexually active with multiple partners, the recommendation for all STIs, including HIV, is to get tested every 3 to 6 months. And the reason why is because I've seen, and it's statistically it's there too on the CDC website. As you may or may not remember from Anatomy and Physiology, 180 days or 3 months is how long blood turns over. So we get new blood, like old blood cells die and we make new blood cells. So 3 months is the time period. So when somebody's being tested for HIV, they may come up negative and then 3 months later come up positive. And depending on how the partners that they had in those 3 months, it could have been then and it was so close to that sexual encounter that the test didn't pick it up. And so when that blood turnover happens, now the test can pick that up. So definitely, and if you're not having multiple partners, the CDC recommends getting tested for HIV at least once in your lifetime. If you just go to your primary care, you can go to the Southern Nevada Health District, but you can also go to your primary care doctor and just ask them when they draw blood to include those STI tests. Sorry, I'm going to be going off on some tangents during this presentation, but it's all related. So when somebody acquires a new HIV infection, as I had mentioned, their CD4 count goes down. As more CD4 and other immune cells become damaged, the body's defenses against the infection begin to decline. This is just a nice little summary of what I've been saying. This says the disease progression. Another thing you can think about with these first 2 bullet points is if you were to work in HIV/AIDS care, then these are the 2 lab values that you'll be looking at the most, the CD4 count and the HIV viral load. Typical progression, this is a nice little summary. As the viral load increases, your CD4 count drops. As this happens, there's more risk for an opportunistic infection and some cancers, as well as nutritional decline. And if this continues to progress and you're not treated, there's an increase of risk for morbidity and mortality. So that's why I recommend to everyone every 3 to 6 months to just get tested for all the STIs, particularly HIV. In the previous slides, you saw what your risk factor might be depending on how you identify. But anyone's at risk. Like I tell my patients, HIV does not discriminate. So you got like that. I always say this, just use protection for men and women. Using condoms is the best defense. I've counseled women who tell me that they're on birth control, and I'm telling them yes, but that protects you against not getting pregnant. That doesn't protect you against any STIs. Believe it or not, these are conversations that you do have with patients if you're working in the infectious disease clinical setting. So yeah, sorry, I digress. Please tell your friends, tell your family, tell your coworkers and colleagues. I know it's like, ew, I don't want to talk about that, but maybe not for you adults. Maybe actually you're really comfortable talking about that. But every chance I get, I always share that with my students, because one of the things that really motivates me as a healthcare provider and as a dietitian personally is just quality of life. Part of my, how would you say this, philosophy, like personal health philosophy, is quality of life, not only for myself but for my patients and my students. So anytime I get the opportunity, I always share this information. And some of it may be simple, and some of it may be, for some of us, maybe something we're hearing for the first time. So I just like to bring that up. This slide is just a table full of opportunistic infections. When being in the field, the most that I ever saw were pneumonia. I did see that, PCP pneumonia, but that's rare, but that does happen if somebody has HIV and it continues to be left untreated. Tuberculosis occasionally, not really. If you work at the health district, you might see it more often. The flu, yes. Syphilis, yes. I saw a lot of cases of syphilis when I was at the health district. Varicella zoster virus sometimes, HPV sometimes, hepatitis A and B. More so, actually, I saw a lot of hepatitis C. So, I'm trying to look and see if there's anything else that I really saw. So if you're looking and you see the salmonellosis and the shigellosis, so anyone whose immune system is compromised means that they're more susceptible to foodborne illness. So you're going to see some of those foodborne illness pathogens in there. Alrighty. Yep, those are the ones I most commonly saw. Okay, so one thing that I tell my patients and students, because sometimes, for example, okay, how do I start? I'm getting ahead of myself. You're probably like me, put the cart before the horse sometimes when you get really excited. So, anytime any of us has a health condition, it doesn't just affect a liver or an organ or just one part of the body. No, it affects the entire body. So one thing I always tell people is, especially with HIV, I mean, this is affecting every single cc unit of blood in your body. Every cc unit of blood has a certain number of HIV virus in it. So that blood is being circulated all throughout the body. So that means that multiple systems in the body, multiple organs, multiple tissues will be affected by HIV. So I always try to tell my patients that, because everything's interconnected, and if they're taking care of HIV, their HIV diagnosis, and they're taking care of their overall body. So if HIV is left untreated, there's a lot of potential issues that can incur. So as you may or may not remember, the majority, I believe it's 80% of our immunity cells are in our gut. So 60% of the T cell lymphocytes specifically are present in the gut, but I'm almost positive, guys, double check me if I'm wrong, but I'm pretty sure in the A&P book it says that 80% of our immunity is in our gut. So our GI tract will be, anyone who contracts HIV will, their GI tract will be affected. HIV leads to depletion of CD4 cells along the GI tract. That makes sense. Increases risk for malabsorption. This is really important. Number one thing that I saw as a dietitian in the HIV world is wasting syndrome. We get into that a little bit later, but that is definitely part of the reason why, is because of that malabsorption. They're not able to absorb nutrients. And also, if you guys have ever had the flu or the cold, then you know that you kind of have a loss of appetite. And even more so, with that loss of appetite, even when you are eating, like for example here, increased risk of malabsorption, you're not absorbing as well as you could have been because your GI tract is affected. So yeah. Oral sequelae. So this is where, because our immunity is down, we are, I shouldn't say we, those who have an HIV diagnosis are more susceptible to things like oral lesions, or thrush is another, it's a overgrowth of candida in the mouth. So fungal or bacterial infections, oral lesions, salivary gland disease. Neurologically too, our brain is affected, or the brain is affected in somebody who has an HIV diagnosis. Pulmonary, so lungs are affected. Persistent cough, fatigue, fever, shortness of breath. Pulmonary infections, like I said, I did sometimes see pneumonia. And then your heart, or the heart, I should say. I'm trying to fix my language here. I worked with a lot of HIV patients, so I use this language a lot. Sorry about that. So, okay. Issues can affect your heart. There can be anemias. There can be neuropathy. That was really common in my elderly patients. But when I say common in my elderly patients, that's because the elderly patients that I was seeing were diagnosed years ago. So I don't know if the neuropathy was because of HIV or if it was caused by old HIV medications. And then wasting. This is a huge thing that I saw in patients, and that was I would say my number one reason for a consultation was due to HIV wasting syndrome. And the second would have been actually overweight and obesity. That was my second reason for consultation. We can get into that later. So for the medical diagnosis, what the doctor is going to be looking for is they're going to be giving them an HIV test and looking in the blood for the viral RNA or DNA. So the other thing that they'll be looking at is a genotype and phenotype. I am not very familiar with this, The doctor that I worked with, Dr. Farabi, was amazing. He would be the best person to talk about this medical diagnosis with. I can get you in contact with him. He's always happy to talk to students. Um, but based on the genotype and phenotype, there can be resistance to certain medications. So that's really important for the doctor to know. And it will affect the choice of which HIV medication the doctor will prescribe. So here are the different stages of HIV. The third stage is then labeled as AIDS. So this is when a patient has less than 200 CD4 count, and or typically has one of these additional opportunistic infections. So a little bit on this. If a patient has HIV, like they're diagnosed with HIV, which means, let's for example say there's a patient who has HIV and their CD4 count is 600. They would not be given an AIDS diagnosis. However, if they didn't take their medications, there's still possibility for death. If a patient has an AIDS diagnosis, so a CD4 count less than 200 and an opportunistic infection, starts going to their doctor, gets their opportunistic infection treated, gets their HIV treated, takes their HIV medications, they can live as long as or longer than the first patient I described who chooses not to take their medications. So one thing I tell people, it's not so much about HIV. It's not that if somebody's given an AIDS diagnosis, they're worse off than somebody has HIV. It's just at the time they were tested, their CD4 count was lower than 200. I have seen patients come in with a CD4 count less than 200, start HIV medications, and their CD4 count go up and go above 200. I haven't seen it come back. I've never seen any HIV patient CD4 count bounce back to 1,000, for example. If you catch HIV early on, there's a good chance that they could stay around the 1,000 area. It depends. All of us start out with a different number of CD4 count, so that's based on genetics. So some of us have a stronger immune system and some of us don't. So patients' CD4 counts can increase, but I've never seen them go back to where they were originally. But that's still good news, because that means if somebody who has HIV or AIDS and they're taking their HIV medications every day at the same time, then they have the same life expectancy, especially if they have proper nutrition and exercising. They have the same life expectancy as anyone else who does not have HIV. And I always encourage my patients that they might actually be better off than some Americans who don't go to their doctors for their annual checkup, who aren't eating healthy and who aren't exercising. Now they are getting their blood work done every 3 to 6 months, because that's what is part of HIV care. They're taking their HIV medications. They have access to dietitians. They have access to other health staff. So they actually could be better off in the long run. And so I always use that as an encouraging word of advice, and also as an encouragement for them to take their HIV medications. So here we talk about AIDS-related wasting syndrome. So this is defined as unintentional weight loss of 10% over 6 months, accompanied by chronic weakness, fever, and or diarrhea for more than a month without a known cause. So like I said, this is my number one reason for consultation. I'm going to sneeze. Excuse me. Sorry about that. Similar to cachexia, hypermetabolic state, low hormone levels contribute to lean tissue loss. Okay, so this is really interesting. Yes, that is true. However, when I was working with HIV patients, this was never discussed. The doctor never brought up hormone levels, so this is really interesting. I was curious to see where this came from, like where this research came from, and how it made it into the textbook, because this might be something that was seen, because a lot of the information that's in this textbook is based on stats from around 2011 and 2012 because the textbook was printed in 2014. So I was really curious about what the textbook is talking about. This may have been something that doctors did see, but I personally, in my years of working with the HIV population and the research I've done on my own, I have not found this. So this is really interesting. But anyway, I crossed it out, but I left it on the slide because fact check is great. I always am appreciative if a student finds something that I didn't come across, because then I learn. I'm very big about instructors learning and students learning simultaneously. Anyone who's ever had me as an instructor knows that I learn as much from you as you learn from me. So yeah, feel free to give me a holler on that one, because I did not find information on that. Okay, sorry, I digress. So the reason why I left is because, like I said, I could be wrong, and I crossed out this oxandrolone because it is an anabolic agent. It's similar to a steroid, I believe. So it would put on more lean body mass, but in my time working with patients with HIV and wasting syndrome, I have never seen this prescribed, and I did work closely with the pharmacists as well, so that was really interesting. A note on appetite stimulants: when I was going through the dietetic internship, again, do the research, correct me if I'm wrong, because I did this research in 2016 and I haven't followed up on that research since then. But actually, I did is it called a meta-analysis? I believe it's called a meta-analysis. When you're looking at multiple research articles on the same research topic. So I looked at all the articles that were available then in 2016 on appetite stimulants and their effectiveness. And actually, in the tests that were conducted, they were not shown to be effective. However, doctors, dietitians say they encounter a patient that has wasting syndrome, has severe weight loss, has a severe loss of appetite. If something were to happen to that patient, and they were called, and that patient died, and they were called into court and asked, what did you do about it? If the doctor prescribed an appetite stimulant, or if you put in your notes that you recommended an appetite stimulant, that is much better than not warranting it at all. So it's unfortunate. I hope that appetite stimulants have progressed since when I did research on them. I looked at Marinol, I looked at Megase, and I looked at a third appetite stimulant. I can't remember the name of it, but I looked at 3, and none of them were found to be effective. And I'm sorry that I don't have the specific statistic. I do have the binder of all my research if you want to check it out sometime. But please do research on that, and I hope that the stats improve on that. But when I was working this past year with HIV patients, the doctor still prescribed Marinol or Megase, and sometimes both. And to be honest, in the patients that they were prescribed to, I did not see a change in appetite. To me, they ate the same amount. I don't know. They told me that they felt like the appetite stimulants were helping. I don't know if that was a placebo effect. Anyway, what I find the most helpful for patients who have wasting syndrome is Ensure. If you look at research of nutrition supplements in terms of like Ensure or I'm so sorry, I work with Abbott products more often. I cannot remember the Nestle brand. Boost. Okay, the name is Boost. That took me a while. I was like, Nepro? No, that's for renal patients. Ensure, research that's been done on nutrition supplements such as Ensure or Boost are found to be effective for weight gain, and I have found that to be true as well. So even though a doctor may prescribe an appetite stimulant, I don't argue with it. I have presented that research to dietitians, but I've never presented it to Doctors, I didn't talk to my pharmacist about it, but he was very smart, so that would have been a fun conversation. But I didn't want to argue because, I wanted the patient to feel better, and I wasn't going to say in front of the patient or tell the doctor, don't prescribe it doesn't work, because maybe that placebo effect is good, or maybe it does have some effectiveness in some patients and not in others. I'm not sure, but I do hope that more research comes out, and I do hope that they are found to be effective. So yeah, the two that I worked mostly with were Marinol and Megaze, and I didn't see side effects from those. But again, I would always recommend alongside an appetite stimulant or as a first line of defense, Ensure or Boost. So treatment, antiretroviral drugs, we're going to get into that. Prevention and treatment of opportunistic infections, yes, yes, yes. It's really great if you can treat them at the same time you're treating HIV. The patient's just going to feel so much better, and if you're able to take care of one infection, then the immune system will do a better job. So this, I left it, but I crossed it out because, like I said, I never saw this as part of the treatment for my HIV patients. Modulation of altered hormone balance, I never saw that, so I'm not sure why that's there. Please, if anybody has info on it, send it my way and share with the rest of the class, because sharing is caring. Maintenance and restoration of nutritional status. Yes, this is where we come in. We are integral parts of the healthcare profession. Okay. So antiretroviral therapy, recommended for all HIV infected individuals. Yes, yes, yes. Reduces risk of disease progression. And so here it says used to lower viral load and hopefully achieve undetectable levels. Yes. So undetectable level means that their HIV viral load is less than 20. What that number means is there are less than 20 HIV virus copies in 1 cc unit of blood. So this is the best that we can do right now. This is where we're at. It's really great that we're here. Of course, there's still great research that's out there that they're really still trying to find if there's a way to eliminate HIV, with the recent hepatitis C treatment breakthroughs, clearing and eliminating hepatitis C. There are some similarities between how hepatitis C and HIV interact in the body, so that's very hopeful and good news for the HIV community. So hepatitis C, if you didn't already know, there is an 8-week treatment that is effective. I believe it's 95% effective for hepatitis C patients, which is really cool. I got to see that happen. It's really cool when you tell somebody that they are disease free. So they're still progressing in the HIV world, but they're not quite there. But having a viral load less than 20 copies of HIV in per cc unit of blood is still pretty great. Also, with those undetectable levels, there was this campaign a couple years back called undetectable equals untransmissible. So that basically, I don't think that's a word. I think, but anyways, marketing, right? U equals U. So if we can get a patient to undetectable levels, the risk for transmission is very, very low. Always we recommend using a condom, but the good news is if they're taking their HIV medication, there's a very low risk, and they're undetectable. There's a very, very low risk of them transmitting HIV. However, that's great, and if they are in a monogamous relationship, that's great. But if they're not and they're having unprotected sex, then they're still susceptible to all the STIs. So I don't always tell patients that, but sometimes the doctor does, and I'm like, cool, I hope they don't take that and run with it and forget about the other STIs. So many catch-22s in this field. Okay, so remember how I was saying that this cool little figure right here is great if we can understand the pathophysiology, how the virus works and how it's replicated and transmitted, and then we can discover some medications, design some medications to stop the transmission, the replication. Yes. So here are the 5 different classes of antiretroviral medications. So there's entry inhibitors. This interferes with binding on the outer surface of the host cell. What's really cool about this slide and this slide is you'll see that the numbers match. So that was talking about number 2. Fusion inhibitors interfere with the ability to fuse with cellular membranes. That's step 3. Reverse transcriptase inhibitors. It halts conversion of HIV RNA to HIV DNA. That's step 4. Integrase strand transfer inhibitors blocks integration of HIV DNA into host DNA. That's step 5. And then protease inhibitors, step 6 and 7, prevents assembly of new virus proteins. So definitely get familiar with this picture right here. This is your best friend for understanding the HIV transmission. So antiretroviral therapy is typically given as a combination of 3 or more medications. We're going to get into that in a little bit. They inhibit the various phases of HIV lifecycle, which is what we just went over. It's sometimes referred to as highly active antiretroviral therapy, or HAART. Specific medications recommended if certain infections present. Yes, that's true too. HIV reproduces rapidly, high potential for mutations and drug resistance. Okay, so on that note, earlier I was saying that doctors will look at the genotype and phenotype and determine whether the patient may be resistant to certain medications or not. Okay, so we're going to be talking about single tablet regimens. So one thing we tell patients is we want them to take their HIV medications every day at the same time, because we want the medication in their blood system for 24 hours so it's constantly working. And if patients decide they'll take it one day, not take it another day, take it here and there, and they're still having sexual relations with multiple persons, there is an opportunity for them to have sex with somebody else who has another strain of the HIV virus. So there are multiple strains of the virus, which is why the doctors test for genotype and phenotype to see which strain the patient has. So if a patient is taking one medication and they have one strain of HIV virus, and they have sex with another patient who has HIV and a different strain of the virus, there is opportunity for mutation. If you know how viruses work, they are survivors. Yes, they need a host, but man, they are crafty. So they can mutate. And if there are these mutations happening, then that's an opportunity for drug resistance. So that's another reason why we always recommend condom use. So that was just the note that I wanted to make on that. If we can get the patient to take their HIV medications, and we can get them to take them every day consistently at the same time, this is best for them and for the HIV community, for all those who are part of research who are trying to find a cure. I mean, we got to work with what we got right now. So let's not create a super mutant HIV virus. Several strains, like I said, may exist in one person, and that this is also why it's good for patients to be in care. What that means in care, yes, taking their HIV medications, but coming to the doctor. I can't tell you how crucial that is. When patients come to the doctor, I don't have the statistic for it, I'm sure it's out there, but of the patients I saw, a greater percentage of them stuck with their HIV medication regimen, who were also seeing their doctor every 3 to 6 months. So every 3 to 6 months, the lab work is done, and the doctor can check can monitor the viral load and CD4 count. And if something's not working, like let's say this patient, actually the medication that the doctor prescribed, it works, but there's another medication that actually could work better, and the doctor was seeing which medication would work best with the genotype and phenotype, they can monitor the viral load and the CD4 count. And if the viral load isn't at an undetectable, which is a viral load less than 20, or their CD4 count isn't increasing as expected, he or she can switch the regimen to a different medication. So, and also to see if there's any other opportunistic infections that maybe were acquired in between seeing their patient last, or a new STI or anything. It's just really great for the patients to be in care, and less chance of stopping their HIV medications, less chance for mutations, less chance for opportunistic infections, all of that. So your book has this lovely chart of HIV medications, but these are all old. Everything on here we would not recommend our patients to take. I mean, there are some maybe that say somebody had a unique resistance, maybe you can put some of these together, but honestly, the new medications are way better. So, what these single tablet regimens are, if you look at, like, for example, Bictegravir, tenofovir, alafenamide, and emtricitabine. So this is 3 medications in one. These 3 medications coincide with having 3 different classes or 3 different types of inhibitors, if you will. So this chart is from pause.com. I can include that at the end of the slide. So I need to include pause.com, that reference, and then I also need to include, I said there was a CDC. Oh, that's right, the STI testing. I will include those websites into the slides themselves. I like having them on the slide so you can see it right then and click it. And instead of the references section at the very end, I like to have it right on the slide. So I will add those. Okay. Sorry, I'm just realizing it's not there. And I apologize for that. I do my research. A lot of this is from experience, so sometimes I'm like, oh yeah, I need to share that with them. Sorry. I had to take a sip of water. Okay, so this slide, like I said, this is pause.com. If you're interested in HIV/AIDS and you're interested in the newest medications, pause.com is your place to go. So what I included in this slide are the 4 main single tablet regimens that I saw prescribed to patients newly diagnosed. While I was working at the Southern Nevada Health District, Dr. Farabi, like I said, he is great. If you ever want to pick his brain, if you're interested in infectious disease, he is your person. So these 1 tablet regimens are best because they include multiple medications in one, so a patient only needs to take 1 medication instead of multiple medications. This is really great news for our patients. And with these newer medications, there's lower risk or lower harm or damage done to your liver, kidneys, and bones. Before, there were a lot of side effects and a lot of issues with the liver, kidneys, and bones. But now with these newer single tablet regimens, way less side effects and way less harm on organs and bones. So this is really great. The two, it's hard to say. Honestly, number 1 I saw prescribed was Biktarvy. It's the newest on the market. It is created by the pharmaceutical company Gilead. And then these others are by, I'm trying to remember. Oh, there's so many. Gilead is the HIV pharmaceutical company that's furthest along in developing HIV medications. But there's also Janssen, which is a sister company of Johnson & Johnson. There is drawing a blank. It's got pink. I'll find you those. But Gilead is really right now number 1. I see them I see them producing a lot of new medications. They also produce Descovy. So Descovy is also a regimen called PrEP and PEP. So for anyone who has a partner who is HIV positive, PrEP is for those at risk for HIV, but is effective at preventing HIV. contraction, I should say. So say you're with somebody who's HIV positive, yes, still use condoms. But if you know that your partner has HIV and they're taking their HIV medication, and then you want to protect yourself, you can take Descovy, but in order for it to be effective, you have to take it every single day. So that is a decision that you and your partner will have to make, but that is an option. We also use Descovy for PEP. Well, PEP stands for post-exposure prophylaxis. So you can, so say you are with a partner and you find out within 72 hours that this person may have had HIV, or maybe they disclosed their status to you later and you had unprotected sex. As long as you take Descovy within 72 hours, your chances of contracting HIV are reduced. They're not 100% eliminated, but it's very effective at preventing the HIV infection. PEP is for people who don't have HIV but have been exposed during sex, at work, through a needle stick or other injury, by sharing in IV needles, so injection drug equipment, or during sexual assault. So I know it's not really the same, but the closest explanation or similarity I can get to PrEP and PEP is like birth control, and PEP is like the morning after pill. I know that it's really not, but those are the closest that I can get to describing how they work in simpler terms. Okay, so we're coming close to the end of the presentation. Thank you for hanging with me. It is going for an hour, so I'm pretty pumped about that. I'm sorry, like I said, I love this area of dietetics and just this area of the medical field. So this slide, I tried to leave it alone. Some of it, yes, some of it, no. There aren't very many side effects nowadays, and the most common I saw were maybe a little bit of nausea, maybe a little bit of diarrhea, but honestly, within 2 weeks of taking their HIV medications, they will not experience those side effects if they are taking those new single tablet regimens that I was talking about. Fatigue is typically a side effect of HIV itself. We have found, when I say we, those working with HIV patients have found that when a patient starts taking their HIV medications, their fatigue actually goes down or goes away entirely. They have increased energy levels. I would also say a more common side effect than what's listed on the slide is weight gain. So I cannot remember which HIV medication it is. There's one HIV medication that might cause a little bit of weight gain. Honestly, it's not statistically significant, and I know this because I've talked to Dr. Farabi about it. Patients may complain that, like, oh, ever since I started my HIV medication, I've been gaining weight. But really, what most likely happened was the patient had severe amount of weight loss. I saw weight loss very common, anywhere from 10 pounds to 60 pounds, because of how long they were living with the HIV virus. And now that they're taking their HIV medications, they're gaining their weight back because they're gaining their appetite back. And if they were diagnosed with HIV wasting syndrome, they were placed on, they were given ensure supplements, and or they are starting to eat more again, like more than they were before. So that's more so the weight gain. And if they had a sedentary lifestyle before and after HIV medication, they still have a sedentary lifestyle. That is the biggest. Those are the bigger contributors to weight gain, not the HIV medication. First of all, stopping HIV medication is not going to be warranted. Second of all, we're not going to switch a patient from a great HIV medication to a different HIV medication that probably won't change their weight gain. So we can talk about that more one-on-one if you want, but as you can see, I'm very passionate about that stance. I'm really, honestly, I can't remember which single tablet regimen it was that possibly caused a little bit of weight gain, but it was very little, something like 0.05% of weight gain possibility due to taking that HIV medication. I mean, it's just so insignificant. Anyways, okay, sorry, because you're gonna have patients that are gonna fight you and their doctor and want to switch medications, and it's not gonna happen, and it's not gonna help. And then long-term effects, we don't see this anymore, but it still can happen. And again, I don't know if this is due to HIV virus itself or if it's due to the medications that they were taking. So I say were because I'm referring to the old medicine or medication regimen. Lipodystrophy, hyperlipidemia, osteoporosis, insulin resistance, and type 2 diabetes, and hypotoxicity. I really think this is due to the old medication regimen. Again, fact check me if I'm wrong. So what's lipodystrophy? Loss of fat and abnormal fat distribution in the body. Subcutaneous fat loss in the peripheral limbs and facial areas. I do see this in HIV wasting syndrome. I do see that. Anyone who goes through the dietetic internship, highly recommend ask a dietitian who knows how to do physical assessments to teach you. You learned a little bit in Nutrition 311, but if you can get with a dietitian that can teach you looking for physical signs of malnutrition, it is a really great skill to have. I would often use it in my own assessments with patients, especially working with patients that are susceptible to wasting syndrome. And then, fat deposits, central, visceral, dorsocervical, dorsocervical area, breast area, abdominal region. Exact cause unknown. See, this is what I'm saying. I'm pretty sure it was due to the old HIV medications because I don't see this often, if ever. And the very few times I have seen this lipodystrophy has been I was right. It is dorsocervical. I was like, I think it was supposed to be a C there. Or we're missing a C there. Anyway, sorry. I just caught that. I was like, no, I said it right. Sorry. So lipodystrophy, the patients that I have seen it in are older patients. And what I mean by older patients are patients that were on old regimens years before the new regimens came out. And lipodystrophy can lead to insulin resistance. So here's an example of what dorsocervical fat, that fat deposit that's associated with lipodystrophy. This is an example of what that is. So I've only seen this in 3 patients, and I've seen a lot of patients in the last 5 years. So, yeah, we can talk about that later. Or not. I mean, that's really all I have to say about that. But yeah, okay. You will encounter patients that will ask you about supplements and ask you about herbal therapies. Honestly, I have not found any of these to assist in any way. I really like that the book points out that there are interactions from certain supplements that could be not good. So I don't recommend any supplements or herbal therapies, especially be on the lookout for if your patient says that they want to take St. John's wort or milk thistle. Those are never warranted in patients who have HIV. And they could be harmful drug interactions. So we don't want that. We want their HIV medications to work. So if a patient ever asks you about that, just say no. You can talk with your pharmacist, but if I don't think you guys caught this, but for example, with some of the medications, like I'm gonna go back to Juluca, because Juluca in particular is the one that you have to be careful of when it comes to supplements. It says here at the bottom, if you take any supplements containing calcium or iron, you should take Juluca together with these supplements, or take Juluca 4 hours before or 6 hours after taking these supplements. So that's when I would talk to the pharmacist, that I worked with, he didn't recommend supplements. He was very pro dietitian. He was very pro getting all your nutrition from food. But if your patient did ask about supplements, multivitamins are fine. They're okay. But he did say, if just like with the Jaluca recommendation, if a patient were to take a supplement that was higher in minerals such as iron or calcium, then to take them 4 hours apart. And honestly, I told my patients, I'm like, look, if you have to worry about taking your HIV medication every day at the same time, like, don't complicate things. uh, Make things easier for yourself. A multivitamin, sure, but don't get crazy on us. Okay, last couple of slides here. This is where you come in. So, poor clinical outcomes, this is across the board. If your patient is malnourished, then they are going to have poorer clinical outcomes. Your nutrition assessment is very important. You're going to want to document their current weight, any weight changes, former weight gain, former weight loss. You'll want to understand viral load, and CD4 counts. If you're interested in this field, great people to learn from are nurses and doctors. One of my number one recommendations, if you go through the internship, is to find great teachers. If I hope that your preceptors can be great points of contact, but if they don't teach you, or they don't maybe necessarily like teaching, find yourself someone who will. I partnered up during my internship with pharmacists, nurses, speech therapists, anybody who would take the time to teach me. I ask them questions and pick their brain, and there's a lot of people in the health industry or healthcare industry that are willing to help you. So if you don't understand something, feel free to ask somebody. Somebody will know the answer and be able to help you. Monitor GI symptoms, of course. Look for clinical signs of anemia or malnutrition. Be familiar with the HIV medications, which medications they're taking, and what maybe some of those side effects are. Be documenting if your patient is using supplements or other medications. You can be integral in finding those drug to drug interactions, supplement to drug interactions, or food to drug interactions. Making sure that you're documenting their typical food intake, whether they're food secure or not, presence of other chronic diseases. So a note on that, I dealt a lot with patients who are low income. So I was funded under the Ryan White grant. The Ryan White grant is a federal grant that states can opt into and get monies from. So the health district has a portion of the Ryan White grant, and that is how I was funded, which is a really great program because any patients that have HIV that apply for the Ryan White program and are accepted, which it's solely based on income, then they get to see a dietitian for free, which is really awesome. And their doctor and their blood work, a lot of things are covered. Medications, sometimes even too, can be covered under the Ryan White grant. So you can see them at multiple times, once a month if you want, 3-4 times a month if you really wanted to. And it was really great getting to work with them because you got to work one-on-one and go explain any aspect of the disease or any aspect that you understood, or that was part of your nutrition assessment. You could speak with the patient about, which I thought was really great and really helpful. You build a great relationship and rapport with your patients. So I say all that because I had a lot of patients that were food insecure. So a lot of the time, I was using 3 Square. I was using their website to find local food pantries and food banks to refer patients to. So yeah, as a dietitian, I felt very integral part of the team, and I felt really great working with the patients one-on-one so closely, and just being able to see them progress and be there too when things aren't so good and help them maybe get back on track. So really rewarding, personally for me, really rewarding field to be part of. You guys have MNT, medical nutrition therapy, so they go more into the nutrition interventions. But these are the final slides that I wanted to end on, what you can do to help. And if you ever want to pick my brain, you're more than welcome. You have my email address. Feel free to reach out at any time if there's anything that you wanted to hear more about that I didn't go over in this lecture. So you'll want to manage or improve their weight if possible, whether they were malnourished before or now they're overweight or obese. You're going to want to help them with their weight. High protein, yeah, it is beneficial. The recommendation, my protein recommendation for my patients was 0.8 grams to 1.0. You could go as high as 1.2, but honestly, depending on your demographic, so I was working with a low income, I did not get very specific, but I did always talk about great protein sources and kept it really simple. If I had patients that were real go-getters, we talked about tracking their food intake, not only using a food journal, but also using apps. So I had very few who were at that place, but yes, higher protein intake for them would be better. Manage insulin resistance or cardiovascular risk factors if applicable, for sure, definitely. Anything that I saw patients that had HIV with kidney disease, heart disease, type 2 diabetes. I mean, I saw all kinds of things. So any area you can help with is great. Managing their symptoms, yes, if they have anorexia, yes, it lists that, or diarrhea, sure. Nausea, vomiting, if you're working with pregnant moms, that's a great place to intervene as well. Any symptoms that you can help mitigate through nutrition, please do. I like that it says that, consider appetite stimulants. Ooh, I forgot to cross out anabolics. I mean, we don't need to worry about all that. And then food safety, yes, may be a concern. As long as they're taking their HIV medications, then they're not so susceptible to foodborne illness, right? All of us have a somewhat risk. But if they're taking their HIV medications, that's helping with their immunity. So in terms of allowing their CD4 to do its job. But if not, then yes, food safety may be a concern. Or depending on their demographic or living situation, food safety might be something that you cover. This is a really nice summary, nutrition interventions. This is found on page... Let's see, what page is this on? Your book is a great resource. Please utilize it. Okay, pages 726 and 727. I have the physical textbook. I don't know if you have the electronic textbook. But this is a really nice summary. For appetite loss, I recommend for appetite loss, I ask them what their favorite foods are, and I encourage them to eat a lot of that. My favorite patients were those that had HIV wasting syndrome and had a liberalized diet. So telling them to have as many cheeseburgers and milkshakes as they want, that was always really fun. If they have appetite loss, I also encourage them to eat with friends or family members. Sometimes that can encourage them to eat. But these are really great tips too. I'm just giving you some additional that are there or maybe not there. For diarrhea, some things that might help. Avoiding fatty or greasy foods, definitely. And then for diarrhea, yes, monitoring fluid intake and electrolyte intake. But also, I would recommend... It says eat bland foods that are lower in fiber, but I'm like, honestly, I would recommend foods that are higher in fiber to try and mitigate that a little bit. For nausea, vomiting, eat small, frequent meals is one of my go-tos for sure. Another thing, yeah, replacing lost fluids and electrolytes. The other one, definitely non-odorous foods. So for any of the pregnant moms that I was working with, I always tried to encourage them to eat foods that were less quote-unquote smelly, that might not trigger that nausea, vomiting. And also, sometimes for some patients, reducing fatty food intake can help too. Okay, oral lesions. Okay, that one, the best thing to do for that, honestly, is to have that treated. But if you want to work with a patient right away that has an oral lesion, sure, you can try some of these tips. I like that it says avoiding irritating, spicy, or acid-containing foods for sure. I'm trying to think, maybe for that, the Ensure supplement still might work. Yeah. That's a toughie. Yeah. So I like that it says eat moist, soft foods or finely diced foods um, to keep your mouth moist between foods. Okay, I can see that. But I think monitoring, yeah, food intake and weight will be good. But if they can get those oral lesions treated, that would be the best. So then they can have they can have more of a liberalized diet again. But these tips work. Alrighty, thank you so much for joining me. Thank you for hanging in there. Our full session I had with you was scheduled for an hour and 15 if we needed to use the time. I'm glad that we kept it pretty close to that time. This has been a pleasure. Thank you so much for joining me. And please, if there's something that I didn't cover or more information that you would like, please feel free to reach out to me. Reach out to Michelle. She's a great resource. And maybe she does a better job explaining this than I do. But I'm really grateful that she had me to guest lecture. And I hope that you all have a wonderful day and stay safe, stay well, and wishing you guys all the best in your nutrition journey. Until next time.